Hello, everyone. Let's go ahead and get started. My name is Susan Lynn, and I'm happy to be the moderator for today's talk titled, What Has the Rehabilitation Treatment Specification System Got to Do with Clinical Reasoning? Your esteemed speakers include Gareth D. Jones, Jamie Gibson, and Tracey Recigno. And we're delighted to showcase our international group of speakers. Let's see, here's some disclosures. Jamie Gibson is supported by UK National Institute for Health and Care Research, Pre-Doc, Clinical and Practitioner Academic Fellowship Award. Gareth Jones is supported by UK NIHR Senior Clinical and Practitioner Research Award. And the views expressed of those are of the authors and not necessarily of the NIHR or the UK Department of Health and Social Care. I'm going to go back just one couple slides here just to give you a visual as I give you a little background about the speakers in case you don't know them. But first off, start with Dr. Gareth Jones. He is the Rehabilitation Clinical Lead and Consultant Physiotherapist at Guy's and St. Thomas's NHS Foundation Trust in London. He is responsible for over 120 acute and outpatient rehabilitation physiotherapists in specialties that include neurology, stroke, and overweight and obesity. Gareth has led developments in clinical quality for rehabilitation at his institution, realized by the development of a manifesto for rehabilitation he co-designed. He recently received an NIHR SAPCR Clinical Fellow Award to focus on strategies implementing the rehabilitation treatment specification system across clinical practice. And then we have Jamie Gibson, who is a senior specialist rehabilitation physiotherapist and pre-doctoral fellow working with Guy's and St. Thomas's NHS Foundation Trust and the National Institute for Health and Care Research. He has collaborated with others, resulting in a teaching program that has implemented the rehabilitation treatment specification system across a physical therapy rehabilitation department. He has published applications of the RTSS to interventions spanning orthopedics, musculoskeletal, neurology, and weight management areas. And then finally, we have Dr. Tracey Recigno, who is the program director and assistant professor for the entry-level doctoral occupational therapy program at Hawaii Pacific University in Honolulu, Hawaii. She has practiced in acute care and inpatient rehabilitation, and her scholarship focuses on leadership development, teaching and learning, interprofessional education, and complementary health practices. She has presented and published her work on using the RTSS as a clinical reasoning tool for entry-level occupational therapy students and is currently piloting using the RTSS as part of a clinical reasoning framework in an accelerated occupational therapy doctoral program. So there are your speakers for today, and our learning objectives are threefold. We will explain at least two ways in which the rehabilitation treatment specification system can be used to facilitate clinical reasoning of rehabilitation clinicians. We'd also like to encourage you to identify approaches for using the RTSS to engender treatment reasoning. And finally, we'd like to discuss assessment approaches used to measure clinical reasoning. And by clinical reasoning, we're also referring to professional reasoning, which is a term sometimes used in occupational therapy. Okay, so we'll start with Gareth.
Thanks, Susan. Hello, everybody. Susan, I just want to check. I can't see the slides that you are hopefully going to share. I wonder if anyone can see them.
Not yet, but we'll hang on.
Okay.
Wait,
Well,
not
we'll
yet?
them. They're, while Susan works on that in the background, I can talk. Good morning, everybody. I think we've anticipated that while some of you might be comfortable with the RTSS framework, others may not be. So yes, my job to kick off is just a quick, brief synopsis of the RTSS for context. So I'm going to keep this simple for those new to the RTSS, and sorry for those who are not new to it, but this is useful revision, or we've got some founders on this call, so yeah, you can see how I go with this. I've never been called an esteemed presenter before, so yeah, that did throw me a bit. Anyway, so from a utilitarian point of view, I guess the RTSS was conceived to state rehabilitation treatments using a common framework with standard nomenclature that was designed to be professionally agnostic. So it could be used across all rehab professions. It was conceived because up till then, it remained difficult to say convincingly, or at least with any precision, what the treatment was, and crucially, how it was developed or how it was delivered. So with that in mind, it's also, I think, useful to point out where the RTSS focuses within the wider rehabilitation services generally. And Susan's got a lovely slide, which she's used before outlining this, but I'll see how good I am at describing visuals for you. So imagine a kind of envelope, a circular envelope, and the outside of that envelope is the whole system of care. Now within that, there's a rehab program. So that space, I guess, includes everything to do with assurance, funders, payers, credentialing, all those kind of stuff, all the structures and processes and operational bits and bobs that need to happen for a rehab program to exist. Now, within that, if you can imagine a Russian doll, we're going deeper into this space now. We've got the care of the patient, okay, and the RTSS focus is in here, but it's actually quite deep in here. If you imagine the care of the patient, a clinician sees them, they need to do an assessment, and ultimately come up with that patient, hopefully with some aims. The RTSS focus is between those 2 points. All right, so it's downstream of assessment, but upstream of the patient's aims. We are interested in treatments, which are represented in the diagram you cannot see as 3 red boxes, but they link straight to targets. And the treatments are hypothesized to achieve direct outcomes on the targets. And that's the key, I think, key point about the RTSS. So within this space, the RTSS is occupied by treatment theory. And RTSS treatment theory is a tripartite structure, which in its singular form forms a treatment component. Okay, now this treatment component, you might have seen these diagrams before, is made up of 3 elements. We have treatment ingredients, which is defining what the clinician does, says, or provides. But the treatment component needs to be complete by considering other elements in a progressive direction of causality, which starts with ingredients. Now, at the end of the causal link between these 3 elements is the treatment target. Now, this is the thing that is targeted to change given the ingredients. And lastly, in the middle, the third element is the mechanism of action, which is a key attribute to include in the treatment theory because it is the hypothesized way in which the treatment ingredient is expected to work and thereby have an effect on the target. I'm hoping, how are you going, Susan?
Can you see it?
Oh, there we go, yeah. So can we quickly go back to the previous slide, please? Thank you. Hey, look, there's the space thing.
Right,
I hope that makes sense. So the RTS focus is in the middle there. We've got treatments directly linking to or making a direct effect on set targets. And if Susan, you don't mind going to the next one or back to the next one. So this is the tripart structure of the RTSS that makes up a singular treatment component, which is a hypothesis with ingredients, making a direct effect on a target via a mechanism of action, which is how the treatment is expected to work. I think if we go to the next slide, Susan.
This one?
Yep. Yeah, another way to consider this is to consider the process of a clinician specifying treatment, which is considered in the opposite direction to causality. So this process of treatment specification, you can see on the arrow on the bottom here. So what a clinician does, I think, is first make a decision on what needs to change, then consider how might this be changed, along with deciding what you can do to affect this change. So the clinician needs to define what needs to change, how might this be changed, and what can I do to affect it. And lastly on this, I think I want to draw your attention to the fact that here we're focusing on treatment theory. Effects of treatment predicted beyond or downstream or distal of the target, for example, aims, are not predicted by treatment theory. They're instead predicted by enablement theory. Now, if we go on to the next slide, which is asks quite a tricky question, I think, or maybe the answer to this should be, yeah, why should we focus on improving clinical reasoning, eh? Why should we do it? Well, the answer, I think, is that in order to achieve effective, efficient, patient-centered rehabilitation that will change our patients' function, we clinicians of all persuasions, and I think the people on the call here are from different specialities, we're not obliged we're not only obliged to describe our specific actions, but we're also obliged to link them logically, or at least coherently, to the desired change in function. And as I hope I've said, well, you know already, the RTSS, we think, provides that link. But here's the thing. The link between description of what we do and how that will make a functional change is clinical reasoning, right? It's at least an important chunk of clinical reasoning. So improving our ability to make these links means we deliver better, more efficient and effective treatments. And I think that's the short answer to the statement here on the slide. To summarize that, I guess, if we go to the next slide, Susan, please. So I think the RTSS will help us to think more cogently about what we do in rehab by paying attention to our choices in selecting treatments. I think it'll also better communicate what we do in rehabilitation to colleagues, trainees, and the people we serve. So the top one, I guess, is about clinicians. It will help clinicians. The second one is about certainly clinicians in their communication with colleagues, but also in education as well, I think. And more precisely and effectively study relationships between what we do and the outcomes we achieve, so that we can figure out what works and why it works, is, I guess, where the RTSS fits into the research field. Ultimately, all this, of course, is to improve the quality and effectiveness of rehabilitation. So I hope I have done a couple of things here. One, introduced or revised the RTSS for everybody, and also kind of pitch why we think clinical reasoning is important and how the RTSS could help it. And I think now we'll go into us discussing a few specific questions to put some meat on those bones.
Yes, thank you, Gareth. So the format for today is what we're going to present. Our panel with 3 questions, and they'll each take turns answering them, kind of like a talk show, but a very scholarly talk show. So our first question is, how have you used the RTSS to engender treatment reasoning? And we will start with Jamie.
Good morning, everyone. As you may have guessed or gathered from the intros, yeah, Gareth and I actually work in the same place, but I think we have different things to speak about today, at the very least. But yeah, we've both kind of been working on a same or similar body of work for about 4 years now. Which started with funding from Health Education England, which at the time was a national body that was responsible for the workforce development of the workforce. Sorry, and this grant essentially was built on the identified workforce need of improving the reasoning and discourse of treatment within our local physiotherapy setting, whether this be case discussions, in documentation, bedside teaching, projects, publications, etc. We just felt like we were not seeing enough treatment theory as Gareth's described in areas where we thought it could live. So to date, we've performed two subsequent pilots of a clinically based teaching intervention for physical therapists of all grades, working in a number of inpatient acute settings. So we've worked in cancer inpatients, we've worked in head and neck surgeries, elective orthopedics, and also older adults as well. And the centerpiece to the teaching program really looked at us scaffolding principles of the RTSS into case-based discussions. Now, Gareth, I know you're going to get into more detail about these in a second, including their rationale of why we think they're important for the RTSS to be used. But briefly, this activity was an activity whereby a therapist would bring a case discussion to someone real life on the ward that week, and would seek advice and expertise from the group, both from an assessment perspective, but ultimately to make decisions about rehabilitation treatment. So that was our centerpiece, and we also went on to develop bits about how to document the RTSS, which we think is important. We've developed an online e-learning package, as well as other small resources like a bibliography, glossaries, and the uses of the RTSS manual handbooks, which there's a second version out there, which is a plug. Now, the two primary aims of these pilot programs were firstly trying to get it into practice right, but secondly, and what links in today, is to measure if there was any effect on clinical reasoning. And as we've been discussing today, our hypothesis is by use of the RTSS, clinical reasoning of treatment will improve. Now, I'm not going to get into measurement just yet. We're going to talk about it later, and we'll get into how we measured and what the outcomes of these measures were. But for now, let's just say we continue to contend that through using the RTSS, physical therapist reasoning and specification, which may be separate, at least specification of their reasoning is improved. But we cannot ignore that adoption of the RTSS has been tricky. And so our current work has focused on how we can support clinicians to start using it more. So this has meant the ongoing designs of RTSS integrations into electronic health records. Stateside, people, folk at the Shirley Ryan are far ahead of us on this, but we've been working on it locally as well. We've really focused on senior clinicians, people that are influential to the practices of their teams. We've tried to support them to be skilled and confident to the point where they can use the RTSS to facilitate treatment discourse within their team. Again, whether that be bedside case discussions or documentation. And we're also trying to push its use in any projects that are about treatment interventions. So the publications that Susan was speaking about at the start, those are our kind of evidence applications of trying to get them in what we produce as outputs as a department. I think that's about all I've got to say at this point.
Wonderful. Thank you, Jamie. And next we'll have Gareth.
Thanks, Susan. Thanks, Jamie. And audience, sorry, this is a bit London-centric sounding at the minute. Tracey can bring in a different vibe, I hope. And also, I appreciate that me and Jamie are physical therapists, so we are biased in what we're saying, I guess, towards that. But we hope it's applicable to across all professions. My view on the statement on the screen right now is, yeah, I agree with Jamie because I work with him, so I would. But yeah, the case-based learning sessions that we actually they've been culturally in play in our department for a long time. But as Jamie said, we decided to use them as a teaching opportunity to embed or try to embed the RTSS. And for me, that is the biggest vehicle I think that to date we've used to engender treatment reasoning. So I'll just explain them, I guess, a little bit. We're using the term case-based learning, but really what this means is a subgroup of clinicians in a room, depending on the team, anything between 4 and 12 people perhaps at any one time. We do them for an hour and we describe a singular patient that the team describes. All grades are welcome and all grades are expected to present something in a kind of rotational basis. So it's interesting. Some people looking in on this thinks some of these happen once a week. Sometimes they're happening every 2 weeks, and in other teams they're once a month or so. But it's interesting that some managers in our organisation look in and think this is decadent. This is not a good use of frontline clinical time. But I cannot disagree more with them, and I have many times in meetings. The structure of these sessions are that whoever's presenting will present the patient case, including the assessment that's been made. They will, I was going to say they're forced to, but that's not quite right. They're encouraged to come up with aims and goals for the patient, and then ultimately to come up and explain or come up with treatment theories using the RTSS that can either be well formed or they can actually be done in real time. There's enough time and space to be able to do them in real time, and we would include in that an expectation that that dosing and any volitional elements would be in there as needed. Now, okay, so we've already kind of made a link, I hope, that the RTSS is linked to clinical reasoning, but why does the case-based learning sessions, why does that particularly engender clinical reasoning? Well, my view, I think, is, and it'd be good to see what you think when the Q&A at the end of this session, but I believe it does because it forces oral and written articulation of treatment theory and enablement theory, because we do encourage people to ground their assessment with patient aims. And I think that's a good skill to learn generally for any clinician in practice, be it that they need to talk to their MDM colleagues, or do family meetings or funder meetings with patients. So they need to be able to orally and in written form articulate why they've done what they've done. So that in itself, I think, helps clinical reasoning. So that's the first thing I think I'd say, how it engenders it. The cases also include clinicians making the links or making a claim about how ingredients via mechanisms of action are likely to directly lead to a change in the target, which is what we said already. So by virtue of using the RTSS, they have to clinical reason. I suppose I should point out that this is not to say that we didn't think people clinical reasoned before they used the RTSS, but we do think it has helped people accuracy or precision in doing so. The other thing that I think it does, these case-based learning sessions do, I think, is provide an opportunity to for a group to sense check how to measure changes in targets. We will never know how the direct influence on the target will happen if we don't at least come up with how to measure that. So these case-based sessions, again, orally and together cognitively, it gives the opportunity to just check really whether it is measurable and how would one do that. and also debate why ingredients should, in theory, work. So we've had some interesting debates about mechanisms of action in these sessions, which I think definitely engenders clinical reasoning. And so by doing this, I believe that clinicians practice they practice using different phenotypes of clinical reasoning without actually knowing it. This is quite implicit learning, I think. So, for example, they'll definitely be using things like problem solving. They'll be using logical thinking and informed decision making. But also, I quite like the term street diagnosis, which I think is kind of code for what others might call intuitive practice. For any PTs on the call, there's been a debate in our profession for a long time about the fight between the art and the science of physical therapy, given that it's a touch therapy sometimes. So I think it's nice that these case-based learning discussions actually aren't anti to intuitive practice. They actually give intuitive practice or street diagnosis some bones, which I think is vital for our clinicians to learn and practice doing. So that's why I think using the RTSS has engendered treatment reasoning. I'm hoping that Tracey now will ask me and Jamie out the water with some OT speak.
Well, yeah, thank you so much. And thank you for the opportunity to be here to give it OT perspective. But honestly, I will say, I think we kind of have some similarities there than differences in, that the street therapy for sure. But I am going to offer a little bit of a different perspective because I'm coming more from, the beforehand, before you become a clinician. And so I'm going to speak from an educator kind of point of view. And I'm sure all of you have had students in your clinic at some point or another. And I'm sure, as an educator myself, I have certainly noticed that often students just kind of select interventions to do with their clients that have like nothing to do with the client's actual deficits. They kind of just proverbially will throw things at the wall and hope that they stick and that they're on the right track without really kind of understanding why they're choosing what they're choosing for their intervention. So kind of, having that experience both, in the clinic as a supervisor of students and then in the classroom as an educator, I decided to try to, I had learned about the RTSS in one of our grand rounds, and I was like, oh, this makes so much sense. And it's such a really interesting way of being able to make explicit what is just very implicit for clinicians. And so I'm going to bring this to the classroom and see how I can apply it to help students understand a little bit more why they're doing what they're doing. And so I integrated the RTSS into a physical disabilities intervention course that I taught to just see if it could help the students. So I introduced the students to the framework through a lecture first, so just to kind of give them an idea, similar to kind of what Gareth did earlier for us at the start. And then I would reinforce that for them weekly. We would have weekly lab sessions where I would ask them to apply the RTSS to client cases based on the content that we were teaching that week. And so this process really required them to fill out a worksheet, and this had them identify what was the goal or the aim or the client, what was the particular activity that they were going to plan for that client that day or that session. But then from there, really kind of narrow down, identify what is the actual target in this activity that you're working on. I know as OTs, we sometimes have a hard time being able to explain what we're doing when we're playing a game of Connect Four, standing at the table. There's a lot of things that are actually happening there that we know kind of implicitly. But again, this is an opportunity for the students to really be able to identify what is that target. Okay, I'm working on endurance. I'm working on strength. And then from there, we would ask them to select the appropriate treatment ingredients and the dosing of what that would look like in their session. And then I think the big piece for us in the classroom was articulating the mechanisms of action. And we asked them to really ground their kind of understanding of that by grounding it in evidence, finding a research article to support that intervention approach, or choosing a theoretical lens or a frame of reference that kind of matched that perspective that would kind of give that it would kind of showcase like why that treatment would work. And so we gave them feedback every week on their assignment so that they could continue to grow and learn and have that reinforced knowledge. And then at the end of the semester, students completed a final treatment plan incorporating those components of the RTSS. And it was so interesting just to see the dramatic difference between what I had seen the year before and actually the treatment plan then after I had done the RTSS. And the students also had to complete an end of semester reflection. And there was a lot of unsolicited feedback about the use of the RTSS. And they had a very positive perception of this framework and that it really helped them to organize their thinking, develop a rationale for their interventions, be more confident in being able to articulate that and speak to exactly why they were choosing what they're choosing. And then for us, really connecting that theory to their client-specific scenarios. So it's kind of similar to what Jamie and Gareth are talking about in those kind of case-based reasoning approaches. But again, we're starting this before they get out there into the clinic and really trying to build that way of thinking before going out there and doing the thing. So yeah, I'll take it back to you, Susan.
Thank you, Tracey. And our next question is, let's see. Okay. Our next question is, does the RTSS influence clinical reasoning? What has been your experience? And we'll start with Tracey.
Yeah, thank you. So I kind of spoke to this a little bit already, but I'm gonna give a big emphatic yes. In my opinion and from my experience, the RTSS really did influence our students' ability to clinically reason. After using the RTSS throughout the semester, as I said, it was such a better experience grading that final treatment plan. There was a lot of really sound approaches to the intervention. And, the students were really better able to choose interventions that actually connected to the client's case. It wasn't just kind of this random activity, but you could really see that interrelatedness to what the deficits were for that client and how they were kind of moving forward with how they wanted to address that. Clinical reasoning, I don't have to tell you all, it's a very abstract process and it's a hard concept for students to fully grasp. But by providing this structured framework, it really helped to concretize their thinking about it. And it kind of helped to tether that understanding of how they can intervene for their clients. And it really helped the OT students to be able to better articulate their decision-making process. And that also then allowed us to give them better feedback as educators. So, we kind of understood where they were kind of getting it wrong from the start, because we could kind of see layered, okay, maybe their target was wrong right off the bat. And so let's back it up and let's rethink about what is a more appropriate target for this client in this point in time. And then sometimes you could see it in the dosing and you're like, okay, you're going to do this one activity once. That's not going to be sufficient to get the outcome that you're looking for. And so it was really helpful for us to be able to give that feedback and understand kind of where the breakdown in clinical reasoning was happening in that process, because we really made it explicit and it made it more of a concrete process for those students. So it really helped them make that thinking explicit, again, really connecting theory to practice. And the big thing for us is that, again, integrating that evidence-based strategy. So we talk a lot about evidence-based practice, but this actually required our students to go out there and find that evidence to support that mechanism of action that they were saying was going to elicit that change for their client. And so we really feel like it fostered that critical thinking and clinical reasoning, and kind of transitioning that classroom learning into more of that practical application of treating clients, because we often kind of are teaching in silos of different content that we're, talking about theory, and then we're talking about clinical conditions, and then we're talking about intervention. I mean, this really kind of helped them to put it all together and understand it in a more coherent way. And so the students, again, they they were very upfront to be like, this is hard. And I think that speaks a little bit to what Jamie and Gareth are experiencing. That's been like kind of hard to get to, see some adoption of that happening. But as they practiced it over and over again, they became much more confident in connecting what they learned in that previous coursework and bridging that knowledge to their clinical reasoning, that it really became, I think, much more intuitive for them, and they felt just a lot better about themselves as little baby OTs going into their fieldwork practice. And so again, I think it just really helped to get that clinical reasoning shored up a little bit for them, and having a practical way to go about that. So again, we saw that with that reflection. They're like, oh, this makes so much more sense now. It was really tough, but I'm glad we kept doing it. I'm glad you kept making us do it, because we feel a lot better about getting ready to go out into field work at that point. So.
Great. Thanks, Tracey. And next, Jamie will give his thoughts.
Yeah, nice. Probably going to start with a grey statement, but I will explain it. And there's fun in the greyness. But I think what we are seeing with the RTSS is that it can affect clinical reasoning in some diverse ways. So different users seemingly finding different reasoning purposes or benefits to the framework, and different concepts of the RTSS maybe having differing effects themselves. But despite this, though, having used the RTSS in a few populations now that work with different populations, providing diverse treatments and with different physical and socio-economical constraints, the RTSS does seem to do what it says on the tin, I think. It forces conversation and reasoning about how to design and think of treatment theory, which is why we're so far in, right, Gareth? 4 years, we're all in. But as I said, there are seemingly different clinical reason effects felt by clinicians, which we've gathered from interviews, focus groups, and anecdotally over the years, I guess, as well now. One notable to me is probably the comparison between a junior clinician and a more senior clinician. When we first started implementing the RTSS into practice, we had quite healthy interests come from our more newly qualified physiotherapists who tend to work in rotational roles. That being probably 4 to 6 months rotations going into new specialisms with new treatment theories quite quickly, right? And I think the framework provided clinicians with a helpful way of learning new treatment theories, but maybe a way of also reconciling common treatment theories across their practice. Now, with more experienced clinicians, the RTSS, I think, can seemingly act as a sense check of their current treatment theories. So we've really got it into it at a service level, perhaps challenging older treatment theories that have been continued. Or for those more skilled, or let's say more confident with the use of the RTSS, it links into what Tracey said. I think it can help explicate treatment theory. So it can add richness and transparency to the treatment theory conversations that they're having with their junior colleagues. But for all clinicians, I think the RTSS utility in our setting for reasoning seems to become more respected with increasing complexity of treatment or patient presentation. Now, we've got to be careful, Gareth and I think, as we first initially introduced the RTSS into these case-based discussions, these were commonly or more typically presentations of more complex cases, which is not what we ever instructed the cases to be, but you can respect why people may have brought them for their colleagues to share on. But for us, we think the RTSS should thrive across all treatment, right? Not just complex treatments. But having said that, clinicians do seem to appreciate particularly the treatment component structure to the framework, that nature of the RTSS, the way they act as building blocks of treatment, when treatment that's complex may feel large, grey, messy when first attempting to tackle. So I think there's something, or we think there's something there with complexity of a treatment. Now, another effect, and yet PT-centric, so thank heavens that you're here, Tracey. But one effect we're seeing in physical therapists we've implemented the RTSS with is specifying treatment interventions that are designed to change patients' attitudes, beliefs, or behaviours. Now, I think, or what we've gauged that as a profession locally, understanding how we directly influence behaviours to either encourage treatment adherence or encourage behaviours of self-management, of healthy lifestyle behaviours perhaps, is growing traction, notably from our professional union and in our national research priorities. But with use of the RTSS, I think we've found a gap. Clinicians definitely struggle to specify their reasoning of these interventions and may well have difficulty clinically reasoning them anyway. So as a group of treatments, we're quite excited and interested to see whether the RTSS can help aid implementation of clinical reasoning of what seems like a newer field of treatment theory specification for the profession. That's enough waffle for me, Gareth. I'll let you take over.
Thank you. I don't know where to go from there, but I agree with Tracey and Jamie with the notion about the undergrads. It sounded like they were going through boot camp or something, but then at the end of it, they went, "That was good. I enjoyed that." And well, same with our junior staff. I think that's been a big eye opener actually. The using Jean, I think Jean's anchors on this call. I'll steal her phrase again. I keep doing it. The old dogs, the clinicians who are kind of set in their ways to a certain extent, are finding it slightly more tricky. But hey, you know, they've laid down their own heuristics for clinical reasoning over lots of time, so it's probably not unexpected that happens. I think, well, does the RTSS influence clinical reasoning? And I think we're all agreeing, yeah. The next question will be interesting because to date, I believe we haven't proven that, which is an interesting one we'll get to in a minute. But I guess I'd add to this debate or this conversation that the RTSS definitely, I think, influences clinical reasoning only if treatment theories are constructed. So, a bit like Jamie said, I think there's a circular argument here. It will influence clinical reasoning if it's used properly. There's no kind of theoretical debate for me about that. As I said, it's tricky to measure it, as we'll come to. What I think I will add to this conversation is that using the RTSS, I think, will actually make clinicians clinically reason when to change their treatments more easily. For example, if the treatment theory is wrong or the patient has changed and we need to change what we're doing with the patient, I think by virtue of specifying the theory, it means it gives an out, I think, for clinicians to say, this isn't working, I'm going to change tack. Which would be interesting, I think, as we'll come to again in the next question, about whether that's a way of measuring whether it's working. It might be that we make more treatment decisions, especially over the long, often rehab continuum that some patients endure across multiple facilities. I believe the RTSS will help us all change our decisions about treatment better, more accurately, at the right time. And I think that's important because it's important to say that clinicians' reasoning process has to include a responsibility for the treatment theories they are constructing, and also, of course, be accountable to the patients, the clients, their family, the funders, meaning we really should be better at altering our plans. And I think the RTSS can help us. So that's what I'd add to this question, I think, Susan.
Yes. So our next question is, do we know if the RTSS has or could have an impact on clinical reasoning? And we'll start with Gareth.
Oh, me again. Good. Yeah, I've kind of alluded to this, right? This is tricky. Do we know? I'm not sure. I'm not sure we do. Is the short answer. But let me talk through this. I think, as I said earlier, Clinical reasoning is happening now. The RTSS is not a panacea. It's not suddenly made everyone use their clinical reasoning. It is happening. Clinical reasoning itself might not be uniformly understood nor documented, but clinicians are doing good stuff out there for patients using their clinical reasoning already. So want to make sure we make that point for the record. But I do think we can say that adoption of the RTSS, though, we think will mean more clinical reasoning will happen overtly, meaning it'll be seen in the documentation. And I think that will happen by us being able to more regularly construct treatment theories. But as I said, the evidence for this is limited. It really is. And I think that's probably down to a couple of things. First, of course, adoption of the RTSS is certainly incomplete. So whatever we may say and however persuasive the argument is that the RTSS will improve clinical reasoning, we're still actually, I think, for clinicians at least, in an educational phase of it being adopted. We're still trying to teach people to use the thing. They're still trying to get to grips with it. So that's the first thing. The second thing, I think, is just because an increase in clinicians constructing treatment theories means there is more clinical reasoning that we can see, it does not necessarily mean it's better clinical reasoning. And how would we assess if it was better? Of course, ultimately, we should be able to look to the clinical outcome level. So if our clinical reasoning is better, patients should get better outcomes. I think, though, there's more. I think we could do that, certainly, but I think, and/or there's a link, there's something I think about the inflections in treatment theory. So I think this is back to this change in clinicians changing what they're doing with patients. I think someone who, well, see what you think about this. I think someone who is better at clinical reasoning will be more likely to set sound treatment theory. Yeah. And they should be better, I think, or more inclined to change the treatment theory when it falters. The big problem over all this big question, though, is defining clinical reasoning within the RTSS context. And I think, Jamie, I had a little look at your notes. You might be talking about that in a second. But I'll finish on one part of clinical reasoning that I think is coming to light, and that's the notion of common factors. I'm hoping, Susan, that you'll be able to put a link in the chat for people with the Lions paper that came out. Was it this year or last year? I can't remember. But I think when the RTSS was developed, common factors, or what are they? They are the kind of implicit notions that clinicians use. So their tone of voice, their touch, the environment, that kind of stuff. I think the term was borrowed from psychotherapy. And I think for brevity, the original RTSS conception was to not ask people to specify them because the burden would be seen to be too much when we're trying to get people to use it. But the Lions paper that I referred to showed by retrospectively specifying a control arm and a treatment arm of an RCT that, in fact, there was a lot of overlap between the two, and a lot, not all of this, but a lot of this was actually down to the common factors. So it's quite exciting, I think, in that clinical reasoning, I think, should lean into this notion of common factors more than perhaps it has done, because I agree with the notion that common factors can be taught and modulated. So I think that's I'm not sure whether anyone else finds that exciting, but I think that is something for the future. I'll hand over to you, Tracey. I think you're next.
Yeah, thank you. I mean, I find that exciting. I'm excited to go read that article. So thank you for sharing that. So I will say, empirically, do we know if the RTSS has an impact on clinical reasoning for students? No. But anecdotally, absolutely. It definitely had a positive impact on clinical reasoning, in my opinion. Students consistently reported that the framework supported their ability to critically analyze their intervention strategies and articulate their clinical decisions. We had several students who came back and shared that they went on to use the RTSS as a strategy for them to help treatment plan in their fieldwork or clinical rotations. And then they felt better able to discuss their ideas with their fieldwork educators and their supervisors and other members of the interdisciplinary team. It gave them just a lot more confidence in being able to have those conversations. However, I think it's just, again, as Gareth is saying, the next steps is to really systematically look at the outcomes of using the RTSS, specifically in education, and to really figure out how to measure this growth in clinical reasoning. I know there's some tools out there, like the self-assessment of clinical reasoning, the clinical reasoning and assessment tool that we might be able to use to kind of assess almost like a pre-post, if students are able to increase their confidence in clinical reasoning, before they're going out into the real world of practice. And I think, it'll be helpful to evaluate those outcomes of using the RTSS as a clinical reasoning tool. And eventually down the line, the students become better therapists. And like Gareth is saying, ultimately, you're going to see that reflected in better patient outcomes. And I know at least here in the United States, I mean, that is really, I think for us, looking at reimbursement models, being able to really connect that to effective outcomes is so imperative for us. And so again, just arming our students with that knowledge, going out there and having a better way to, advocate for their clients and patients, and having an ability to speak to their rationale for why they're asking for this treatment or this piece of equipment or what have you, I think can, again, just only help their clients in the future. So yeah, thank you. I'll pass it back to Jamie.
Nice. I finish off. Huge responsibility. Echoing again the other guys, I think anecdotally there's good stuff there. Empirically, we're not there yet, right? We've only piloted stuff, and maybe there's preliminary evidence we could say within our populations we've done this work with. But I think, yeah, pertaining to measurement, I like Gareth's point about, okay, what exactly are you trying to measure? I think when we first did this, trying to find definitions of clinical reasoning to support what we were going to measure was tricky. And again, reviewing the literature, which we're doing at the moment, it still is. Getting a definition of that. Clinical reasoning is a vast subject. And I think there's a nice Young's paper that talks about how the definition ultimately needs to flexes to the boundary of the person using it. And with the boundaries that we had of physical therapists and treatment-specific clinical reasoning, we couldn't come across measures at that time which were nice work-based psychometrically tested things that would say, yeah, these guys have changed because of the RTSS. But we did use the self-assessment of clinical reasoning rubric, which showed some modest improvements across all teams. We even tried to make a homemade rubric that assessed the quality of problem list formation, treatment plans, and treatment goals, which we thought would all develop as by using the RTSS. And yeah, again, we found modest improvements, and really the improvements seem to be higher in a non-experimental setting, but seem to be higher in the groups that adopted it more. So, preliminary wise, it's encouraging. And look, again, these measures are not perfect, and I'm definitely not selling our homemade measure, right? But I know Gareth and I are definitely involved, and others are involved in scoping a review of the literature across the allied health professions, speech and language, occupational therapy, and physical therapy, to see whether there are measures that could get at what the RTSS could change. So I think the hope is towards this year or maybe next year that might be a piece of work that's done. But I'm excited to see what happens with that. But again, supporting the concept that, look, adoption's not there yet, and it feels too early in our setting to measure effect. I think we've always been about, let's really make sure that good use of the RTSS is realised, both in case-based discussions, documentations, and maybe other settings before we jump to measuring its empirical effects. And look, our study is small, with physical therapy biased as well. There's loads of people, loads of professions loads of specialisms, loads of different forms of treatment for this to be tested in, hopefully in an experimental manner. And I for one am looking forward to getting involved in more of that in the future. But yeah, why not? Sure, the RTSS can affect clinical reasoning. Let's go for it. And
thank you all. So I just wanted to share some RTSS resources. If you're not aware, they're on our group page in the ACRM website. So if you go to acrm.org and find our Community Rehabilitation Treatment Specification Networking Group, you'll see these resources there as well. Also, if you have not already seen that we have a new version of the RTSS manual out, and think it's on its way to being uploaded. So if it's not there yet, we're just waiting for it to be uploaded. And then we will only have a few minutes for Q&A. But if you have a question that you haven't typed into the chat, feel free to unmute and ask. But I wanted to invite you to join our networking group on the fourth Tuesdays at 3. And we have our task force reports there, as well as sometimes we have speakers. Okay, does anyone have a question?
Not really a question, but a comment. I came in late, so I apologize, but something struck me that Gareth said about this idea of transmitting across the care spectrum, right? So if we see a patient in the, in acute care hospital and inpatient rehab, outpatient rehab, home, I'm wondering if the RTSS could really help with that transitional information so that the continuum of care can be more explicit. So not a question, but I really like that idea. And there's definitely a need for it.
Agree.
Any other questions or comments? Well, if you do think of a question, you are welcome to submit a question online. We have a form, and we will get back to you within a couple weeks with the answer, hopefully. And that is a free resource we also provide throughout the year. And we are so glad that you attended our webinar today. And we invite you to join our group if you want to learn more. And thank you all. Have a great day.
Thank you. Thank you for the presentations. Bye-bye.
Thanks everyone for coming.
Bye. Thank you.
Great job, everyone. You guys are awesome.
I'm so sorry about the tech in the beginning.
You're good. You got it.
All right. It's all right.
Oh,
How did that land, Susan? Do you think that was all right?
Yeah.
Yeah.
It's awesome.
Tracy, you're awesome.
Oh no, you guys are like killing it over there. I'm like a fangirling.
Jamie are bored of ourselves, not we?
I'm bored of you, Gareth.
Yeah.
Thanks for coming, Tracy. Yeah.
This is so fun. Susan, thank you for setting this up, Susan. This was a lot of fun. So thank you for inviting.
Oh, you're welcome.
Tricky to pull together. Good work.
Yeah,
great work.
I think we had at least 14 people. Did anyone get a count?
Yeah, that's what I saw.
Yeah, that was a good number. Okay, so I forgot to tell the people that they have to wait 48 to 72 hours for the recording to get uploaded to our webpage.
Right.
But
they were
quite quick.
Yeah, thank you for the reminder too. I was in like a networking group, and then with Andy, I guess, was leading it, and then it just stopped I don't know, it got deleted off my calendar. I'm like, well, I gotta figure out. So thank you for the reminder. I'll get back to the main networking group and then.
Okay, you know, they changed over from Zoom to Teams, so the calendar invite disappeared.
That's it. Yes.
So I think, yeah, you have to accept, you have to find the calendar invite with the new Teams link.
No. Okay.
But I can also have them make sure they have your email.
Yeah, that would be great. Okay, I
Yeah.
can do the networking too. So, well,
Okay.
thank you.
All right. Well, thank you so much. You guys were
Thanks, guys.
terrific.
That was fun.
Thank you.
Thank you.
See you soon.
All right. Have a
Thanks,
great
bye-bye.
Okay,
day.
bye.
Bye.
Bye. Bye.